I'll discuss about intestinal obstruction. Intestinal obstruction may be of three types. First is acute, which is sudden in onset. Severe obstruction persists unless interfered. Then subacute, obstruction less severe than acute, history of repetition and a free interval period. And chronic obstruction is gradual narrowing. Obstruction is present all the time. It is not so severe as acute or subacute. Now the main discussion topic is acute intestinal obstruction. Acute intestinal obstruction, it is of two types. That is, first is mechanical obstruction or dynamic obstruction. Proximal part of the intestine contracts to overcome distal obstruction. So there is presence of peristaltic movement at the proximal part. Hence it is known as dynamic or mechanical. And B, that is the adynamic obstructional paralytic ileus. When peristaltic movement of proximal part is lost, the gut is exhausted. It is known as paralytic ileus. Now, types of the mechanical obstruction, there is simple obstruction, that is, there is obstruction but vascularity of gut is maintained. But in case of strangulation, when the blood supply is lost due to any reason. And another is closed loop obstruction, obstruction presence both proximally and distally, intervening portion of gut being affected. Example number 1 is volvulus, that is closed loop obstruction, volvulus. So this is number 1. Volvulus is twisting of the guts in its own axis. Second is acute appendicitis. Now the division what I have talked about, I am quickly revising. That is, intestinal obstruction may be acute, subacute and chronic. Acute may be mechanical or dynamic, that is peristalsis is maintained. That may be simple, blood supply intact. Strangulation, blood supply jeopardized. And closed loop is double obstruction, intervening part affected. And another is adynamic or paralytic ileus. Now what is simple acute intestinal obstruction? Simple acute intestinal obstruction cause is in the lumen, that is foreign body, trichobrachia, in trichobrachia, phytobrachia. So trichobrachia is ball of hair and phytobrachia is ball made of undigested fruit scale. Clumps of worm, fecalid, that is imprecipitated calcified feces, growth arising from wall and block the lumen. Gallstone ileus, stone from gallbladder entering duodenum through cholecystoduodenal fistula. It gradually gets bigger in size and obstructs intestine, causes paralytic ileus. So that is the cause in lumen. But if you think about cause of the wall, that is congenital atresia, traumatic, accidental or operative, then inflammatory, tuberculosis, Crohn's disease, neoplasty, that is malignant stricture at rectosigmoid junction. And lastly, the outside wall, any band or adhesions, commonly postoperative adhesion or inflammatory bands resulting from peritonitis, any growth or any swelling pressing intestine from outside. Example, enlarged lymph node, big ovarian cyst, and superficial inguinal ring. Pathophysiology, it is in an intestinal obstruction, whatever the cause is, proximal part contracts vigorously to overcome distal obstruction. It produces acute colicky abdominal pain, acute abdominal distension due to distension of the proximal part, then vomiting, and ultimately absolute constipation, as there is nothing is passing in the distal segment. As the obstruction is not relieved, intestinal contents accumulate more and more to cause distension. The distension of intestine is due to collection of fluid, collection of gas. Fluid comes from salivary secretion 150 cc, gastric secretion 250 cc, bile and pancreatic juice is 1000 cc, and succus entericus is 3000 cc. These are the fluid. So fluid comes from salivary secretion 150 cc, gastric secretion 250 cc, bile and pancreatic juices 1000 cc, and succus entericus 3000 cc. Air comes from swallowed air, fermentative gas, diffusion of the carbon dioxide into the lumen from the distended vein of the wall. When obstruction is not relieved, regurgitation of content into the stomach, which leads to vomiting, causes loss of fluid and electrolyte, that is dehydration, exhaustion, weakness and fatigability. So what are the summary of the clinical feature? First is acute colicky upper abdominal pain, abdominal distension in small intestine, distension mostly in upper abdomen, in large intestine, distension in the flank, and in vomiting, absolute constipation. Then features of loss of fluid and electrolyte. What will be the investigation to do? How will you proceed to diagnosis? First, do routine examination of blood, that is bleeding time, clotting time, ESR. Then do special investigation like sugar, urea, creatinine, electrolyte, serum amylase. And the most important part is radiology. That is, radiology is the straight X-ray of chest and straight X-ray of abdomen. Multiple fluid levels with gas shadows will be found. Distended intestinal loop. Each distended loop has special feature. Ileum, it is featureless. Ileum is featureless. And distended jejunal loop is, there is one effect, that is concertina effect due to volvulus conniventis, that is jejunal fold. So that is the volvulus conniventis jejunal fold. And lastly, distended large bowel is found. That is one thing, that is hostration. So three things are found in the X-ray of the acute intestinal obstruction. First is multiple fluid levels with gas shadow. Distended intestinal loop, it is prominent here, distended intestinal loop. Each distended loop has special feature. Ileum, it is featureless. Distended jejunal loop is concertina effect due to volvulus conniventis and for jejunal fold, and distended large bowel, there may be found hostration. Now what will be the treatment of acute intestinal obstruction? First, do conservative treatment by suction, the gastric suction by Rice tube, intestinal suction by Miller-Abbott tube or Cantor's tube. These special tubes are introduced in small intestine by fluoroscopic control. That is one endoscopy that will help with the rest by fluoroscopy. So that is the fluoroscopic control. IV fluid is given, that is glucose and electrolyte. These fluids are administered on the base intake output chart. Now output is measured by amount of suction, urinary output, invisible perspiration 500 cc and respiration, that is 500 cc. Antibiotic by parenteral route is given. Antibiotic by parenteral route to combat infection from the organism in the intestinal lumen, which may proliferate under favorable circumstances. Indwelling catheter should be done to measure 24 hours urine output. And lastly, patient is kept under the follow-up clinical assessment done whether distension increases or decreases. Distension whether increases or decreases, whether amount of suction increases or decreases. Another straight X-ray is done whether number of fluid level increases or decreases. If condition improves, distension subsides, suction diminishes, and numbness of fluid level less. That is, treatment continues. And if deteriorate this condition is deteriorating, that is distension is increased, suction is increased, fluid level number more in radiology, operative intervention should be done. Now what is the operative surgery? Operative surgery is done under general anesthesia. Abdomen is opened by a lower right paramedian incision. Lower right paramedian incision. Cecum is identified. Ileum, cecum is collapsed. If cecum is collapsed, obstruction in the small gut. If cecum is distended, obstruction in the large gut. Junction of the collapsed and distended part in site of obstruction. Obstruction is relieved surround according to the cause. In lumen, enterotomy is done. If in the wall, then resection, and if in the wall resection anastomosis, stricture area is resected. If obstruction from the outside, then bands are removed. So these are the two treatment. So in lumen, enterotomy is done. If in the wall, the pathology is in the wall, resection anastomosis is done. Stricture area is resected and the rest of the area is anastomosed. If obstruction from the outside, bands are removed. Now the step is viability of gut is assessed. Viable gut is present, then that is pushed back into the abdomen and abdomen is closed. And if non-viable, that is not living, that is part of the intestine is dead, then that is resected and the viable part are anastomized, that is resection anastomosis is done. How do you assess the viability? Under normal viable condition, the characteristic features of the gut are color maroon, peristaltic movement present, lustre present, and pulsation of mesenteric artery well palpable. On needle prick, there will be bleeding. So thus you can identify the viability of gut, that is color, bicolor, peristaltic movement, lustre and pulsation. Color will be maroon, peristaltic movement present, lustre will be present, and pulsation of mesenteric artery will be there. On needle prick, there may be bleeding, and if viability is compromised, there is color changes to black, peristaltic movement is sluggish and does not cause bleeding, that is by pinprick, and pulsation do not return satisfactorily, and gut looking non-viable. Normal condition Reverse gut is viable. To assess viability, hot mop should be applied. Now, few of the pathology, that is the intussusception, that is, it is a condition where a part of intestine is telescoped in adjacent distal segment. It can produce intestinal obstruction, that is acute, subacute and chronic. Pathological anatomy of the intussusception is, first the layers are entering layer, that is this is the entering layer, then returning layer, and another is enseething layer or covering layer. Now entering layer and returning layer, the first two layer from inside is termed as intussusceptum, and enseething layer is termed as intussuscipiens. Apex junction of the entering and returning layer, and neck is junction of returning and enseething layer. So this is the anatomy of the intussusception. Then the etiology. First etiology is idiopathic, but the probable factor is hypertrophy of Peyer's patches in the ileum. Peyer's patches are aggravated lymphoid follicle, and during this period of the weaning, the time of change of food habit in a child, this proliferates and there is proliferation of intestinal bacteria. Peyer's patches are stimulated, they grow and produce a lump which is responsible for intussusception. So that is in case of the newborn child during the period of weaning, the time of change of food habit. Then second is symptomatic or secondary cause, that is submucosal lipoma, papilloma, papilliforous carcinoma, inverted Meckel's diverticulum, inverted stump of appendix. All this can cause intussusception. Types are antegrade, in direction of the peristalsis, and retrograde is opposite of the peristalsis. Now jejunogastric is efferent loop of jejunum enters into the stomach through the opening of gastrojejunostomy. So example of retrograde intussusception is jejunogastric, where efferent loop of the jejunum enters into the stomach through the opening of gastrojejunostomy. Now venous obstruction, so it causes red current jelly, and arterial obstruction may cause gangrene. Then sequence of events are: an intussusception progresses, mesentery gets sandwiched between entering and returning layer, and vessels are compressed. Veins are compressed first due to superficial presence of vein, and then leads to venous congestion and edema, leads to pouring of blood and mucus into lumen, which finally may come out per rectum as red recurrent jelly. And when arteries are compressed, there is vascular geopathy leading to perforation, gangrene and peritonitis. To start with, it begins as simple obstruction which changes to strangulation. So what are the etiologies of intussusception? That is the acute common in children due to hypertrophy of Peyer's patches, and symptoms will be acute abdominal pain, distension, vomiting. On examination, a sausage-shaped lump is probable concavity looking towards the umbilicus. The lump hardens when the child cries. There is emptiness in right iliac fossa because ileocecal region pulled upwards. It is known as sign de dance. Then the treatment of intussusception is conservative, that is by nasogastric suction, Brile's tube, IV fluid, glucose and electrolytes, and parenteral antibiotic. An attempt made to reduce intussusception, a barium enema from height, so that heavy barium can push the apex proximally to relieve the intussusception. Sometimes water may be passed from a height. When conservative treatment fails, surgical intervention demanded. What are the operative steps? Under general anesthesia, abdomen is opened by lower right paramedian incision. The intussusception is identified. Attempt is made to reduce intussusception not by pulling from the proximal end but by pushing apex from distal end. By gentle maneuvering, the apex can be reduced. In case there is problem in the neck, adhesion is repeated by tip of little finger or tip of the hemostatic forceps. In process of intussusception, apex is first part to enter, last part to reduce. Problem in cases proximal pulling, since the gut is friable, it can tear off. So after reduction, viability of gut can be assessed. If viable, it is kept inside. In non-viable cases, resection anastomosis is done. If intussusception is not reduced, then resection anastomosis. Summary: reduction by pushing the apex, that is successful or not successful. Successful, then viability is assessed. Viable, keep in closed abdomen. Non-viable, resection anastomosis. And not successful, resection anastomosis is done. Now volvulus. So what is about volvulus? Volvulus, it is rotation of gut in its own axis. Site of volvulus generally sigmoid colon, cecum, small intestine, and rarely in stomach. Sigmoid colon is commonest. Cecum if there is mesentery, and small intestine, especially in newborn, that is volvulus neonatum. And volvulus in sigmoid colon, it is anticlockwise rotation of sigmoid colon in its own axis. Etiology is short attachment of root of mesentery, long axis of mesentery, loaded colon, especially someone takes huge amount of food after a prolonged fasting, and parietal attachment of gut, which acts as a fulcrum. Then pathophysiology, as the rotation occurs up to 90 degree, nothing happens. When rotation occurs 180 degree, there is only luminal obstruction, blood vessels on the wall not affected. Rotation for 270 degree, 1.5 turn, venous obstruction takes place. It leads to congestion of vein, diffusion of carbon dioxide from distended vein into lumen. It leads to huge distension of abdomen, especially over the flank. When rotation occurs more than 1.5 turn, arterial obstruction takes place. There is gangrene, perforation, and peritonitis. Now, clinical features are age, commonly older people at late middle age, acute colicky abdominal pain, huge distension over the abdominal, especially over the flank. In no other variety, intestinal obstruction is so much of distension as in a volvulus. Now, vomiting usually absent or occurs very late, and it is one example of acute intestinal obstruction where there may not be vomiting. Passage of no flatus and feces. Investigation is first straight X-ray of abdomen, huge distended colonic shadow practically filling left half of abdomen looking like motor tire. So that is the straight X-ray of the abdomen, huge distended colonic shadow and practically filling left half of the abdomen. So there is a typical a sign, that is the coffee bean sign. Now, conservative is rise to suction, IV fluid, parenteral antibiotic. Attempt is made to derotate the gut by passing sigmoidoscope, that is sigmoidoscopic derotation, and sigmoidoscopic correction. Through sigmoidoscope, a flatus tube is passed distally, and with the help of flatus tube, it is only helpful in early cases within 180 degree rotation. And operation is done when conservative treatment fails. Operative treatment is demanded. Steps of operation: abdomen is opened by general anesthesia by left lower paramedian incision. Volvulus is identified. Distended gut with rotation. Volvulus is corrected by rotating the gut in a clockwise direction. OT sister passes a flatus tube under surgeon, and surgeon negotiates the tube into the distended colon. The gas in the colon escapes into water. The gas gut collapses. Viability of gut is assessed technically, and technique is already discussed how to assess the viability of gut. If viable, kept inside; if non-viable, then resection anastomosis. Precaution to prevent recurrence of volvulus: if the loop is unusually big, then the redundant portion may be resected followed by anastomosis and plication of the gut. There is 18 stitch over the serosal lumen remains intact. What is compound volvulus? It is nothing but ideal knotting of a sigmoid volvulus. Volvulus of sigmoid end is surrounded by a loop of ileum. Straight X-ray shows distended gas shadow of colon and ileum. Here chance of vomiting is more than simple volvulus because ileum is obstructed. Features of large gut and small gut obstructions are present. Treatment is surgical, that is derotation of gut. And then another topic is there, that is the paralytic ileus, where you should know normal physiology, causes of paralytic ileus, and the clinical features. And this will end total the intestinal obstruction episodes. So, paralytic ileus, a dynamic type of obstruction where peristaltic movement of gut is paralyzed, that is ileus means peristalsis. Then normal physiology of peristalsis. Peristalsis is conducted by sympathetic and parasympathetic intrinsic plexuses present in wall of guts. Parasympathetic contracts, sympathetic relaxes, alternate contraction and relaxation that will cause intestinal movement. And submucous plexus of Orvac present in the submucous coat of the gut, and myenteric plexus present between the outer longitudinal and inner circular fiber. So there is intercommunication between two plexuses. Submucous plexuses of Orvac plexus present in submucous coat of gut, and myenteric plexus present between outer longitudinal and inner circular fiber. Now, what are the causes of paralytic ileus? At end of mechanical obstruction, the gut loses its peristaltic movement. The tired horse can't be whipped. So, operative there is crude or rough handling of the intestine during operation. So, at the end of the mechanical obstruction, operative causes and post-operative cause like post-operative leakage and peritonitis and perforation. Bacterial peritonitis causes also paralytic ileus. Inflammation of organ like acute appendicitis, cholecystitis, peptic perforation, and strangulation of gut, that is vascular geopardy. The gut dies. Reflex paralysis, that is retroperitoneal hematoma, fracture spine, plaster jacket for tuberculosis of spine. Now, clinical features, this is intestinal obstruction without pain. Second is special feature like distension of the abdomen. Third is vomiting, loss of fluid and electrolytes, dehydration, and muscular weakness, and silent abdomen with occasional metallic sound. What is the investigation? Straight X-ray of abdomen for an electrolyte. And treatment is conservative, rise tube, suction, IV fluid, periparenteral antibiotic, indolent catheter, and operative is abdomen is open and the cause of obstruction is removed. So this is all things about intestinal obstruction.